And recording just started. Okay. I'm gonna go ahead and start sharing my slides. All right. All right. So welcome everyone. I'm so excited that so many of you have been able to join us on a Wednesday at lunch for the role of the behavioral health consultant in behavioral health screenings in primary care. I'm going to tell you a little bit about me, and then I'd like to know a little bit about you. I'll have a couple of questions that you can answer in the chat on the next slide. So I am a assistant professor at UT Austin Dell Medical School in the Department of Population Health. I also hold the role of behavioral scientist director of the Family Medicine Residency Program, where I see patients with my family medicine residency program in a PCBH model and serve to upskill the family medicine residents as well as the entire primary care team in primary care behavioral health. Another part of my role is luckily I am contracted to work in an FQHC, and so I assist the FQHC in implementing the primary care behavioral health model across their more than 15 clinic system here in Austin, Texas. So before we get started, I'd love if you could put your name and your location in the chat, your role in the clinic, and just one question you would like answered by the end of this presentation. After the didactic portion of our presentation today, we'll have a discussion where we can address some of these questions as well as any questions that come up as we are going through the presentation. All right, I'm going to take a quick look. All right. Got Nashville. Got a couple other people in here. I see many of you have already entered before I even asked you to put in your name. So thank you for doing that. Got Arizona. Got directors of behavioral health, Washington clinical social workers. Awesome. Thank you for letting me get a quick snapshot of who is all here today. Houston, Texas. All right. All right. Boise. All over the place. Wonderful, wonderful. All right. So we're going to move on to the next part of our presentation. And so the objectives of this presentation at the end of this session, I'm hoping that you'll be able to identify the importance of screening in primary care, discuss the role of BHCs in behavioral health screenings, and outline important factors to consider when deciding to implement a screening process. When discussing any team member's role in primary care, I always like to go back to the purpose or the mission of primary care and how to do it well. So I love this definition. High quality primary care is the provision of whole person integrated, accessible, and equitable healthcare by interprofessional teams that are accountable for addressing the majority of an individual's health and wellness needs across settings and through sustained relationships with patients, families, and communities. It's a mouthful for sure. But if we were to apply this to the screening process, if screening helps achieve this goal, it would help identify a variety of biopsychosocial concerns to promote equitable health and accessible health care for all persons. The screeners would then trigger the interprofessional integrated team to work together to address the patient's, family, or community's health and wellness as a community. Another way to think about the mission of primary care, if you can't remember this very long definition, is the 4 Cs, which meaning this is where patients most often enter the healthcare system and it's highly accessible when they need it. The second C is comprehensive care, which again is that whole person care across concerns, but doing promotion, prevention, treatment, rehabilitation, and that is appropriate within the primary care context. The third C is coordination, which is integrating all of that person's care and needs within one setting. So basically, primary care is the home base. Even if they go to specialty services, we are still contacting all of that care. And then the last one is continuity, which is establishing a longitudinal relationship and mutual trust over time. So looking at the statistics of the people who come to primary care, we can see that there's a high need for identification, so screening, and treatment of behavioral health needs in primary care. We know that 84% of the time, the most 14 common physical complaints have no identifiable organic etiology, and 80% of individuals with a behavioral health disorder will see their primary care doctor at least one time in a calendar year. And about 50% of all behavioral health disorders are treated in primary care. And of the population that goes to a primary care facility, about 20 to 40% of those people have a behavioral health need. In terms of medication, we know that almost half of the psychotropic agents prescribed are by non-psychiatric primary care providers. So it's more than fair to say that primary care has earned its name as a de facto mental health system of the United States. I'd like to show you this video about the importance of behavioral health screenings in a healthcare system.
When you walk into your doctor's office, your doctor can't look at you and immediately know what you need. There are some things that are going on inside your mind and your body that may not be evident. Systematic screening is a way for practices to make sure that they are identifying the full range of needs that patients have. And some of those needs are often very hard to articulate. A lot of patients, when it comes to things like preventive screening, a lot of patients will know when they need their colonoscopy, or they may not remember the exact date, but they may have some ideas about when they're due for their mammogram. But when it comes to things like mental and behavioral health, those things are sometimes harder to talk about. So when somebody's feeling sad, they may not articulate that. But if it becomes part of standard practice, that everybody gets asked about how they're feeling emotionally, it becomes normalized and desensitized, but it also becomes routinized in the practice. Practices are organizations that do things out of routine. So if you can make something just a standard operating procedure, something that a person does with every patient every time, then it's likely to not be forgotten and it's likely to get done. And having tools that support that process can be really helpful. So when the MA or the medical assistant takes you back to the room, if they have a prompt that makes sure that they ask every patient, maybe it's the
Oops. Sorry there. One moment.
PHQ-2, how they're feeling. Well, it's just like taking blood pressure on every patient. They do it with everybody, and they typically do. Really creating a routine for the practices so that things aren't forgotten, but you're also making these behaviors absolutely normal. They are expectations that patients have. When I go to the doctor, I expect that they're going to ask me about my state of mind, just like they're going to take my blood pressure. So now it becomes something that I can talk about with them. And I feel like they're not focusing on me because I'm somehow different or special.
All right. So I'm wondering if you can put in the chat or unmute what stood out to you about this video and about doing systematic implementations of behavioral health screenings. Yes, so they should be routine, just like blood pressure. something that you do regularly, something that helps destigmatize it, being a part of routine healthcare. Yes, that if we don't ask about this and create a context in which we say it's okay and we want them to talk about it, that we could definitely miss it. Just navigating the chat here. Alina, do you see any other comments? Okay, wonderful. So those are both wonderful comments, and I want you to keep that in mind as we move forward.
We just had a new comment.
Okay, see that. Normalizing discussion about their mental health, their behavioral health. Yes, again, creating that context that we want to know about that whole person perspective. All right. So in primary care, screenings have to be brief and accommodating for the fast-paced, population-based health culture of primary care. So the two types of screening practices we are going to discuss today are universal screening and selective screening. So universal screening is a brief screen administered uniformly to an entire clinic population, often with the goal of detecting common conditions or concern in your patient population. For example, I work in an FQHC, so one of the universal screenings we use is the social determinants of health screening to help us identify unmet social needs that may otherwise go undetected if we didn't have that universal screening. Now, a selective screening is a structured brief tool assessing a particular condition in a high-risk population. So an example of this is a selective screening for pregnant women for diabetes. If you ever had been pregnant, you probably remember drinking that really not so tasty sugary drink before you had to take this test. So I'm wondering, what are some of the universal and selective screenings that you do in your own clinics or have heard people do in their clinics? And feel free to unmute or chat. All right, we got PHQ-9, audit, wonderful, PHQ-2, PHQ-9, prepare, PHQ-9, G87, G87, okay. Awesome. So we've got a lot of mental health screeners, and sometimes those can be either universal or selective screeners based on what your particular clinic is going into. And I'm wondering, with some of these screeners that you identified, were your BHCs a part of this conversation about how to implement it, who was going to implement it, or in the process? Simply putting a Y or an N in the chat can be helpful. Wonderful. Great. Okay. Yeah. We got yes and no's. All right. Right now we got almost a 50-50 split. Okay. More no's. All right. So hopefully today I can talk to you a little bit about how BHCs might be able to be included in that process. All right. So I just wanted to go over some of the ways that clinical pathways or screeners might look different in different integrated care models or clinical pathways and perspectives. It can be tailored to achieve the purpose of the particular initiative. For example, in a clinic that has integrated the clinical pathway of SBIRT in their system, they have adopted a universal screening to help identify, deliver brief intervention, and refer individuals to a higher level of care that's screen positive for problematic substance use. If someone is doing the PCBH model in their clinic, they may also institute the SBIRT screening protocol and have other universal and selective screenings to meet the needs of the overall clinic population. If someone is engaging in COCM, screening may be used to identify patients to be assessed for the appropriateness of COCM model and to be placed on the registry. And if you were working in a trauma-informed clinic, you may decide to constitute a universal screening of ACEs to inform your practice. So just seeing how screenings may be used in different purposes based on what level of integration or model, clinical pathway, or perspectives you might be using. So if we're looking particularly at the primary care behavioral health model, since we already talked about the mission of primary care, we have to look at the purpose of primary care. So the PCPH model is a team-based care approach to manage behavioral health problems and biopsychosocial influenced health conditions as well. And what we're hoping is that we can enhance the ability of the entire team to manage behavioral health concerns, resulting in an improved clinic health overall. And in order to achieve the mission of primary care and primary care behavioral health, BHC must adopt the following principles of ways of being in the primary care culture. So it's important to review the basics of a BHC's function in primary care before answering the question about what is the role in screening. As you can see, a theme of my presentation today is when you have to make a decision or answer a question, going back to the basics and the mission of that particular initiative or setting. So in reviewing a BHC's function, the GATHER acronym is a nice way to remember how to do primary care behavioral health. So BHCs are meant to operate as generalists, meaning that they may know a little bit of information across a lot of diagnoses, as well as across a lifespan, or know where to get that information. A BHC is accessible, so making same-day access a high priority. And BHCs work in a team-based care model, so adapting to the flow of their clinic and their team's need, such as providing intervention before, after, or in between the PCP appointments. A BHC sees a high volume of patients in order to reach as many patients as possible to encourage the improvement of the overall health of the clinic. And a BHC is an educator to the entire primary care team to improve the clinic's overall management of behavioral health concerns. Finally, BHC visits are considered a routine part of healthcare, meaning someone doesn't have to have a specific diagnosis to see a BHC, and routine pathways can be created to encourage team integration. So if we were to apply the principles of GATHER to our question about the role of the BHC in the behavioral health screening in primary care, we can outline the following elements. To embody the function of a generalist, it would be important for a behavioral health consultant to have a general knowledge of screening recommendations across diagnosis and understand their clinic population needs. The BHC should also be accessible to the team to help with different areas of the screening process, such as figuring out when you're going to do an intervention, when it might be administered, curbside consults, problem solving the implementation of the screening process, as well as be considerate about how that screen might also impact their own accessibility to patients. BHCs can help investigate how the screening will impact the team-based flow. And the BHC can also help identify how the screener is helping the BHC meet a large volume of patients' needs, as well as if the current BHC to PCP ratio can accommodate the people identified by that particular screening protocol. The BHC can educate the team on the interpretation of the results, use and recommendations of those screeners. And lastly, the BHC can help design the pathways to integrate the screening process into routine care. So again, going back to that systemic implementation, making sure that this is common practice in primary care. So diving a little bit deeper into the GATTR acronym, you can see in the left corner of my slides which information that this will particularly map onto in the GATTR acronym. Don't worry, I'll go in order, GATHER. And so what I really wanted to highlight is a place that a BHC can begin to bolster their knowledge about screening recommendations is the U.S. Preventative Service Task Force. And here you can look up different conditions that the clinic is thinking about implementing a screening process for, and there are recommendations for the entire population or specific populations. It's important to remember that these are just recommendations and they're not mandates and should be considered based on the population needs of the specific clinic. You can see that the recommendations range from A, which is highly certain that there is would be a benefit in adopting the screening process, to D, which is recommended against due concerns for no benefit or potential harm outweighing the benefit. Then we have I, which kind of outlines that there is insufficient evidence at this time to make a judgment about if it would be helpful to implement a screening based on that particular population and that particular concern. Here's just some examples of behavioral health screenings and other listed on the U.S. Preventative Service Task Force. You can find the specific condition as well as the population, the grade of the recommendation, and the year it was published. If you notice, the top three of the behavioral health concerns are behavioral health concerns, and they've received a B grading. But if we go back to the example of a selective screening of pregnant women, you can see for an asymptomatic person who is pregnant prior to 24 weeks of carrying the baby, it receives a B grade as well. So these behavioral health screenings and other health screenings can be on the same grading level. Another thing I wanted to point out is that it does a really good job about specific populations. So for example, if we were to look at screening for gestational diabetes for people who are pregnant past 24 weeks, then that current recommendation is insufficient. So it does a really nice breakdown. Along with the knowledge of what conditions are recommended for screening in patient populations, it's important to have a general knowledge of screens to assess conditions. The list on this slide outlines common screeners used in primary care settings. Other screeners can definitely be used. It's just important that the BHC and their team to think about the purpose, the sensitivity, the specificity, the cost, the reading level, and the brevity of the screening tool in a primary care setting. You can see that a lot of the screeners on here are ones that you identified. Other screeners I have seen in clinics include the following. So insomnia severity index, the diabetes distress scale, the MDQ, the PEG may be administered if there's a specific concern going on. Screeners such as the quality of life symptom inventory and the Duke Health inventory may be able to give the primary care team a quick look at a patient's functioning or overall satisfaction with their quality of life, which is important when we're focusing on functioning and improving quality of life in the PCBH model. In order for BHCs to have a general knowledge of the clinic population, it may be important for them to be a part of the needs assessment, or at least have access to the needs assessment so that they can help guide screening recommendations and see what would be most beneficial and limited cost to their primary care partners. For example, if the United States Preventative Services Task Force recommends that an intimate partner violence screening is about a grade B, but you know that your county has one of the highest incidents in the state of IPV, then you would more likely to screen for IPV than not. Another example of this is if the clinic identifies a health equity concern in the clinic, they can design a screening protocol, referral, and intervention process to address the inequity and promote standardized care for their patient population. For example, if clinics notice that Black individuals with depression are less likely to be referred to a behavioral health consultant, your clinic may institute a PHQ-9 cutoff score to standardize the process and improve equitable access to the BHC screen if that process has not already been put in, and that's the particular barrier that's going on. If we move on to the A and the T of the GATHER acronym, the BHC should be accessible to the team in helping with different areas of the screening process. It is also to be important that the BHC be a part of this conversation, because the creation of a new pathway can have a negative impact on the accessibility to the BHC to the entire patient population and the ability to meet that needs that the clinic pathway may create. So if the clinic does not have the BHC ratio to support the BHC schedule, may be filled with just one presenting concern that comes from that particular pathway, and reduce the accessibility of patients with other concerns, moving away from a population health approach. If we talk a little bit more about team-based, when implementing a screening tool, BHCs can help identify and gather information on the process that may impact different members of the team. BHCs can bring a unique perspective as well as help complete a program evaluation of the decision to implementation process. Often I know when I have a new BHC, I typically have them shadow different members of the care team to understand the flow of the clinic and everyone's role. This may be a unique perspective to bring to a screening process and can be repeated when you are considering implementing a screening process. So they would be able to have conversations about, okay, who would be the one administering this? How might it impact the flow? Would you be doing it per paper? Would you be doing it per iPad? And they might be able to see how that might lag somewhere, or who might be the best person to input data based on the roles of the different team members. So moving on to high productivity, BHCs can identify a screening process that may help to increase the number of individuals referred to BHCs by identifying specific clear criteria for an automatic warm handoff or referrals. This helps the BHC and the primary care team potentially link patients to BHC services that may have not been connected without selective screening processes. Often I see this as very helpful if you notice that your BHCs are getting a lot of traditional mental health referrals, and not getting many of those health behavior referrals. And so one clinical pathway you might institute is anyone with a new diagnosis of prediabetes would be an automatic referral to BHC in order to increase integration around prediabetes, diabetes, and maybe other health concerns. So in the role of educator, the BHC can provide the team members the knowledge about the screeners gathered through the different resources we discussed. So the United States Preventative Services Task Force, their understanding of the common screeners, understanding of the needs assessment that went on, and help problem solve the workflow and program evaluations. We can also be an important part of discussing the difference between screening for a particular concern and functional analysis. Understanding screening is typically used for early identification, or maybe used to track outcomes over time, but doesn't necessarily mean a definite diagnosis. And there are other pieces that are necessary in order to receive a diagnosis beyond just screening positive. So after the BHC and the team have put everything together, they can actually institute a clinical pathway and outline the workflow, so how it will be implemented into routine care. On the screen, you can see a sample clinical pathway that is from the AIM Center. Now, the AIM Center actually contacted HealthPoint, who works in a primary care behavioral health model, and adjusted their particular pathway to work in COCM. But you can see at the top what they identified is a selective screening. So they're going to be giving, oh, sorry about that. They're going to be giving the PHQ-9 to people who have a presenting concern for behavioral health or OB. And the person who will be giving that screener is the front desk. And after the front desk receives that screener, they're going to give that to the medical assistant, who will then collect score and enter the PHQ-9 GAD scores into the system. And then based on the particular score of the screener, so if a patient scores somewhere between 0 and 9, then the medical assistant can ask if they're interested in a behavioral health appointment, or if they're not interested in the behavioral health appointment. If they are interested, they can reach out to the behavioral health person and get that person scheduled for an appointment or put them on the registry. If they're not interested, then the PHQ-9 is given to the primary care provider to review and share the results. Now, if someone is 10 or higher, right, the MA again contacts that behavioral health consultant to see if they might be available, if the patient is interested, and then the behavioral health consultant will complete a visit and add the patient to the registry. If the behavioral health consultant is not available, then the MA would give the primary care provider the PHQ-9, and they would discuss the particular results with their patient. And you can see that if the BHC is not available, then the primary care is the one to kind of assess suicidality and risk around maybe a positive score on question number 9. If you look a little deeper into this, you really have to see that there's many decisions that they made. So this clinic had to decide where that screener was going to be delivered, who would be entering the data in the system, and what handoffs would look like based on scores and what players may be doing different parts of the screening protocol. So in answering the question to screen or not to screen, it's important to look at the United States Preventative Service Task Force recommendation. It's also important to get a good idea of what your clinic needs, your specific population, right? One clinic is one clinic, and that will look different across your clinics. And then understand how it might impact or how it might be implemented into routine care. So who, what, when, where, and how this will be implemented, and the cost benefits of that for your particular primary care team or clinic. And then finally, do you have an available intervention? Do you have the right BHC PCP ratio to be able to offer the individuals that do pop positive on these screening protocols to be connected to those resources? One of the worst things you can do is actually ask people a question and not get them linked to the resources or even figure out how to help them about it. So in summary, the BHC is an important part of all the stages of deciding of a screening process. So implementing, evaluating, providing interventions, and developing the screening pathway. So at each step of the PDSA cycle, BHCs bring their knowledge of systems perspectives, skills of evaluation, and behavioral health change skills to the screening process. It's important to mention that this can be examined at any point of the screening process. So for those of you who have BHCs were not included in discussing how it might impact the system, this may start when you are actually reevaluating the screening process and see how you might be able to change it to get the particular mission you're trying to establish by using that screening process. So that is kind of like a whole conceptualization of what the PCP and BHC might be doing in order to do the behavioral health screening process. And we are at the end of our presentation. And so I'd love to open it up for questions as I look through the chat to see if there are particular questions you put in. But feel free to unmute or add questions in the chat.
I'm not sure if you already answered this, but towards the beginning, when you asked them what is one question you wanted answered, Bianca asked, how can we handle the 30-minute time limit when we have patients that have multiple issues that are affecting their emotional well-being? And then
Right.
someone else responded saying, like, they're agreeing, I'm finding this hard as well. The warm handoffs tend to be more lengthy and have more needs covered than can be covered in 30 minutes.
Okay. And so if you're particularly talking about the screening process, right, the screening process is going to help you get quick information about a particular concern that the PCP is giving you that handoff for. So if your PCP is giving you a handoff for depression using the PHQ-9, if your PCP is giving you a handoff for insomnia using the insomnia severity index, or if other for diabetes, maybe using the diabetes distress scale, and that's going to give you a quick snapshot of information that you might not have to ask about in more detail throughout your clinical interview. So that's ways you can have screeners help you shorten the process. My other question is, with the complexity of people's concerns when they come into primary care, it's really important to have an outline, like a structure of your visits. And so if you haven't received any training in the contextual interview or the functional analysis, I would highly recommend that, which helps you kind of touch on a variety of concerns in a concise way in order for you to get a clear picture. One of the things I forgot to mention at the beginning of our echo here is that mental health of Greater Houston area, they actually have a behavioral health consultant certificate program that does specifically this, and they're actually accepting applications right now until December 1st. So having a particular structure and being willing to get snapshots and provide a quick conceptualization to inform an intervention.
Hello, I am Lana. I just kind of want to reflect on what you just stated, Brittany. As I'm learning more about the role of the, consultant and stuff, I think my general concept is more directive, less reflective. Right? Having a little bit more structure to the process allows us to manage the time better. And I'm not doing great at doing that yet, but I'm working towards it. But I wanted to see if that reflection was accurate.
Yes, yes. So thank you so much for sharing that. And you're right, it's a hard transition. I was originally trained as a licensed marriage and family therapist and transitioned to integrated care, primary care behavioral health later on in my doctoral program. And so there is nuances and different ways of being with the patient that help you really tailor those particular visits to be succinct and efficient and effective. And so often when I'm training new BHCs, you will see a lot of reflective and summary statements, just because naturally that's how that's how I was trained as a therapist. But a good part of that is to remember if you are trained in the contextual interview or functional analysis, there's a particular portion of your interview called the conceptualization, where you are sharing what you think is going on based on all of the context of the patient, so you can save your reflection or your summary for that particular section. So it doesn't necessarily have to be deleted, it's just placed in a different place.
Gotcha, thank you.
A great question. The other thing I wanted to just mention in considering the multiple issues is that, as you're doing a behavioral health consultant visit, you may use different screeners at different points of your longitudinal relationship, right? It's episodic care. And so let's say you're treating someone for depression, and then you suspect that maybe you get new information as you're going along that it may be maybe some PTSD. You may give the PCL5 screener to help gather that information as well. I think it's hard to balance this idea of, getting a diagnosis as well as getting a functional basis of what's going on in the patient's life, as well as what's important to them. And so screeners can be a good way to gather quick information so you can get both of those things. Yeah, so I read earlier in the chat that Bianca mentioned touching base on BHCs and the suicide risk assessment, particularly when there is active suicide risk during a consult. And so this is a really good question. This is one of the protocols that we particularly outlined in our FQHC. And so when we're considering a protocol in the primary care team, right, that doesn't just include the behavioral health consultant. So for example, if the PHQ-9 is being given by the medical assistant, and then that information is given to the PCP, you can decide as an organization if the PCP might deliver the Columbia suicide scale before they actually contact the behavioral health consultant. And then if the behavioral health consultant is not available, making sure that there is a crisis line or another place that another team member can come in to get that particular patient connected with the resources. And so deciding with your team about how far down into the screening process you will go before engaging the behavioral health consultant. The other thing is that sometimes that might vary based on the busyness of the primary care provider, right? As a BHC, one of our goals is to help lighten the load off the primary care provider. So if someone is really, really packed and running behind, then they might bring in the BHC earlier in the suicide risk assessment than a particular protocol that the organization has organized. Thank you for all these questions. They're great questions. All right, any other questions about any of the areas that a behavioral health consultant might be able to help in the screening process? I know when I was first even reviewing this, I was like, there's so many places that BHC can be involved, and how to kind of talk about leadership about how to be a part of those conversations or give free feedback on those particular screening processes. Yeah, so let's see. I do have a list of typical screeners that are used in primary care behavioral health. I can't remember where it is right now, but it's in my email, so I can send it to Alina to send out with the PowerPoint if that's helpful. Wonderful. Yes, definitely can do that. Now, this list is from what I understand, a comprehensive list of all the screeners that are done in primary care, not necessarily primary care behavioral health. And so you may see some of these screeners are very long. And so again, just making sure that you look at these and how it may fit into your own clinic flow, and based on the model that you are particularly using and the goals of that particular model. Another good conversation, just as I'm thinking here too, is often the type of EHR that you're using has particularly already pre-populated screeners in it. And so, for example, our organization works with Epic. And so there were already screeners put in it, but let's say our team decided that we wanted to implement another screener, and we did that. We wanted to implement the pediatric symptom checklist, 17 for our pediatric populations. You would have to contact kind of the builders of your particular EHR to upload that into the system. And sometimes that can take a long time. So just considering how you would implement it into the entire EHR if you do want to institute a new screening protocol. And I know we have quite a few new BHCs on here. So Alina, I don't know if this is this is typical. I'm happy to answer just new BHC questions as well.
Um, if y'all have any other questions, please still let us know. And then I did see a lot of comments in the chat about everyone being a new BHC and you guys are new to the role. And that's where the course that Dr. Houston mentioned earlier, the Behavioral Health Consultant Certificate course comes in. I dropped the link in the chat. So we're doing this course. It starts in February of next year, and our applications will be closing on December 1st. And Dr. Houston is actually one of our faculties, and we're just wrapping up our first cohort. And Dr. Houston can speak more to how that helps our students. But definitely, we'll send the link in the follow-up email if you guys are interested in joining the course. You'll definitely be trained. And hopefully all your concerns of being new will be taken away because we have our professionals. So Dr. Houston, if you want to speak more to that.
Yeah, so I highly recommend this course. I've sent a couple of my BHCs to this course too, and this course is online modules, so you might be working it at your own pace, as well as there are office hours. Alina, is it every month?
We have twice a month.
Twice a month, where you get to talk to the faculty about any of the content that were coming up for you, or just even things that are happening in your clinic. And it's one thing that's particularly unique about this is that we actually have 2 in-person skills training opportunities where the behavioral health consultants come and get feedback and do a behavioral health, a new patient appointment with a standardized patient, so that they can kind of address some of those concerns many of you were talking about today, how to balance getting information, building rapport, and delivering an intervention in a 30-minute appointment.
Yeah, and we also have a info session that kind of goes a little bit more in depth to this program on November 1st. We'll drop the registration link in the follow-up email. But if Dr. Houston, if you don't have anything else to add, we can definitely wrap up the meeting. I see some people starting to leave as well.
Sounds good. Again, thank you all for coming to this ECHO, and I hope you come to other behavioral health consultants ECHO. Like I said before, I know it's a hard decision, a hard transition, and so these are super helpful in answering questions.
Thank you, Dr. Houston. Yes, our next ECHO is